Okay, we'll be talking about insulin therapy initiation and optimization. And although it is difficult to change, we need, for the sake of the patient that we manage, to feel comfortable initiating insulin, recognizing the patient that needs insulin, and always be ready to optimize. And by the way, diabetes is the second leading cause of death in South Africa. Although we are always updating our knowledge in the HIV, it comes way below diabetes when it comes to mortality. And another thing that we need to be mindful of is that it has been 100 years now since insulin has been discovered. The only time that I've seen people excited of giving or starting patient on insulin was whenever they reach out for Actrapid. And giving Actrapid to patients that have hyperglycemia does not address the need for those patients, because you will never achieve HbA1c, prevent complication, and prolong life by giving random Actrapid to your patient. So this is basically not caring about diabetes, because when we care about diabetes, we set a target of HbA1c. And to get to HbA1c target, oh, you blocked my.
Yeah, just click back on the screen. Sorry. Just go back on the screen.
Okay. It's you need both the fasting blood glucose and the postprandial blood glucose on target, isn't it? Mm-hmm. And the target is individualized depending on the duration of the disease, the motivation of the patient, depending on the complication, depending on the resources that we have, the risk for hypoglycemia, drug-drug interaction. You can choose and decide with your patient which target you choose and would be appropriate for your patient. And usually by default, we take 7%. And that 7%, or regardless of the target that you choose, they tend now to go even below 8. They choose 7.5 rather than 8. But if you can get it below 8 for those that are at risk of hypoglycemia or have a shorter life expectancy, it's fine. But do your best. The patient should never be symptomatic hyperglycemic wise. So regardless of your HbA1c target, in the morning, the fasting remains the same. Every single patient should. It is critical to know these things, because you ask the patient to go do self-blood glucose monitoring. They should be aware as they leave, what do they expect as a reading in the morning. So regardless of the target, it should be between 4 and 7 when it comes to fasting. But the postprandial will depend on your patient target. So if it is the default, you can, or your patient can afford to get a postprandial between 4 and 10. And when it is less than 6.5, it should never go above 8. And for the more lax HbA1c, we can allow the patient to go up to 12. So those are the things that, as you prescribe insulin, because they need to monitor, you need already to present that to your patient. So, is that the way you feel? You wish you could just kill yourself and run away. And patient is not only some of the prescribers, but is also the patient. Whenever the talk about insulin come up, they really feel as if they did fail. Why can't we just embrace insulin and try to keep it simple and safe and not worry? There is no reason for us to be worried when it comes to giving insulin to our patient. And we need to embrace insulin because we don't have any other choice. Because as the disease progresses, there will be a time that the pancreas will fail the patient. The patient is not failing, it's the pancreas that is failing the patient. And going forward from monotherapy, they will need combination therapy, and ultimately they will need insulin. That is the story of diabetes, basically. And failure to do that, if you don't adjust your patient treatment, your patient will remain hyperglycemic. And as you can see, as time goes, if you are not intensifying your patient treatment, they lose control as time goes. That is why we need to be grateful that insulin is there in our setting, for example, because we don't have any other treatment to come allow us. And many patients, type 2 patients, will require insulin ultimately. So whenever you diagnose your patient with type 2 diabetes, you need to know that the majority of them will ultimately need insulin. So now, when do you bring up insulin? When do you usually bring up insulin? When do you usually discuss insulin with your patient? Yes, but when do you start discussing? When do you start that discussion about insulin?
Part of your discussion with the diabetic patient, the first time you're seeing it, because eventually it might go that way. Yeah, so you need to start educating them.
Don't wait for Cape Town day 0. You don't wait for the pancreas to go dry for you to talk about insulin from the time, because even when you diagnose your patient, they say 50% of the beta cells are gone in most of the patients. Some of them, it's more than that. So who knows how close they are to getting to the day 0. So you should get them prepared already. So we should change, and that is also what makes it difficult for patients, is that for 5 years, no one ever spoke about insulin. And when they come, boom, you need the insulin, they feel as if they fail. So let us not wait the day they require. The day they require, it will be a reminder. Remember what we spoke about? It is the day to day. Fortunately, we have insulin for that. And from time to time, as they come, we should be visiting the indication and the time that they would need insulin. Never should we be using insulin as a threat for our patient. That's why they end up not using it. At the time we tell patient, continue like that, you'll get insulin. It's counterproductive. It is a blessing. Fortunately, we have insulin. So the day the pancreas fails you, you will be bailed out by insulin. So, and another reason why we should be celebrating insulin, it is almost a drug that has unlimited efficacy. The only time that it fails, it's when the side effect comes in. The only times that it fails, it's when you didn't educate your patient enough. The only time that is failed is when you don't optimize your patient treatment. You are so fearful of hypoglycemia, for example. That is the only time that the insulin. So if it was not about side effect, we could just, they wouldn't have spent money to create another drug or to discover another drug for diabetes. So, and what are those side effects? What are the side effects? Because those are the things that you need to discuss with your patient from the get-go. Hypoglycemia and weight gain. Mainly, those are the main complications. People forget, and people, we need to remember that at the time patient will fail insulin because they will stop using insulin once they've noticed that they've put up a lot of weight. We need to, even if hypoglycemia is there, when you compare to type 1, you can see that there is less hypoglycemia in type 2 compared to type 1. And if type 2 or type 1 patient don't have any choice than to carry on with it despite the risk of for hypo, why should we be that worried? Just to be able to monitor, warn the patient, and optimize the treatment accordingly. And we need to remember, the more we tighten our control, the higher the risk for hypo. So you cannot prescribe insulin and not touch or educate your patient about hypo and the risk for hypo and how to manage. Weight gain, as we say, it is a big issue. You cannot brush that away. If you really check your patient weight regularly, you will see that they put weight. By 1 year, they can put up almost 2 kg. By 5, and after initiation, they can even go 24% of patients can gain up to more than 5 kg. So it is something that we really need to be mindful of. So now, do we know our insulin? Can we identify them, or we are colorblind? Then we are sorted. Huh? You're colorblind, so you're off the hook. So you can always identify, because are we mindful of the colors? Because remember, it's all about educating your patient. It's about the patient moves up and down. They might not bring the folder, or the pharmacy might not be able to print that day, or the folder is lost. How do you reboard that prescription? Which insulin do you pick up? Those are some of the tricks that we need to remember. Atropine is yellow in our setting, and protafen is green, and atropine is brown. So it is easy, even when you prescribe and your patient goes to the pharmacy, they should already be warned, because a pharmacist can dispense the wrong drug. So if they know and they can identify that this is not my color, even if they don't know the name, they can bring it back. Because one of the reasons why insulin fails is by giving the wrong insulin to the patient. So whenever we prescribe insulin, we need to remember they are mainly human insulin and they are analog. Unfortunately, in government, we only have access to human insulin. We don't have access to analogs. But patient that comes from private have analogs. And you need to know it is insulin, but they are not exactly the same. So you need to be able to explain to that patient that come back to us after they retire, what they lose with switching now to human insulin. And whenever you prescribe insulin, you need to be mindful of what is the peak, first the onset time, and what is the peak time. Because with the peak comes the risk for hypo. If by the peak you didn't eat, or that's why they get hypos while they are waiting for us there. The time of onset, as you are excited giving Actrapid, you even start checking the effect of Actrapid earlier than when it kicks in. So all those things need to be done. How long does it last for you to be able to give another dose or two? For example, when we give them Actrapid, it should be 12 hours between the two injections. Do we tell them that? So the PKs of the insulin we should always be mindful of them. So again, it starts working in 30 minutes. It peaks by 3 hours and lasts 8 hours. So that one shot of Actrapid, by the time they are home, it's gone. Tomorrow morning, how many times did you see them? They were in casualty, you gave Actrapid, they come to Ward 5. Somebody does the same thing, expecting a different result, which is called? If you no, we are not. So, but that is what is happening. So you want to do the same thing and expect a different result. So you understand also whenever the patient is Actrapid part of the regimen, which is in Actrapid, they need to schedule the meal accordingly, because it takes 30 minutes for the insulin to change and to be able to start being absorbed. And the other thing is that with the regular, we'll talk about that with regular insulin, when you give, for example, the peak, whenever it occurs, it is way beyond what happened naturally. The peak after eating, the peak is earlier than the peak in Actrapid. That's why people, if they don't eat, will easily get hypos. And that's why you need to remind them to take that 30 minutes, not inject and eat, because otherwise they won't have food by the time the peak is reached. So this is our protophane, isn't it? It peaks by 6 hours and the last 12 hours. What are the implications? That if we had to apply our mind, ideally, protophane should be used twice a day. So it is not a surprise that you get your patient with blood glucose that might not be on target. Mind the fact that it might have been just because the action has lapsed already. So we spoke about this, and this is just a summary. We don't have longer insulin. We don't have analog. So in short, there is a difference between short acting and fast acting or rapid acting. The analogs that are short acting are called fast acting or rapid acting, while the regular insulin is just a short acting insulin. And our protafen is intermediate because the slow lasts more than 24 hours. And as you can see again, the difference, the other drugs, when they are longer acting, they basically don't have a peak. And if they don't have a peak, the risk for hypo is lower compared to the basal that have a peak. What happened with protafen, or what would be happening with atropine? But it's just another way of presenting these drugs, and try to remember, we call atropine, which type of insulin? You call it, it is a premixed, but PK-wise, it is a biphasic, because there is a first peak that comes from atropine, then there is a second peak that comes from protafen when it kicks in. That's why it is biphasic. If you can see the protafen, so there will be this first, then there will be another peak from protafen. So if really you wanna prescribe insulin to care about your patient diabetes, it should be scheduled insulin, not as needed insulin, because that's what we do. When you give atropine, it is not scheduled. It depends on when you tested your patient. You need to think and act like a pancreas when you prescribe insulin to your patient. It means try to cover, because the pancreas produces basal insulin all the time. And whenever somebody eats, they top up, they increase, there is a pulse production of insulin to try to take care of the food. That is one of the failure of human insulin. That's why in private, they use analog, because analogs tend to emulate the pancreas better than what human insulin does. And with human insulin, as we spoke again, please be mindful of hypos, and not only be mindful of hypos, that patient can get hypo at night and wake up with hyper. And that risk is less with analog compared to when we put our patient on protafen. So again, whenever you prescribe, you need to know which insulin does what, isn't it? It is all about, does that insulin take care of the prandial glycemia, or is that insulin taking playing the role of basal insulin? How do you assess the action of basal insulin? Remember the triad with the fasting, with postprandial, for us to be able to achieve our target. And this also will determine what you tell your patient about self-blood glucose monitoring, because you might be monitoring the wrong blood glucose, and adjust treatment and get your patient gaining too much weight or getting too much frequent or severe hypoglycemia. The basal insulin take care of fasting blood glucose. So your patient on protafen, at the beginning, you only need to monitor the fasting. When they get to the fasting, but they don't achieve the target, then you mind the postprandial. Your patient on oral, you only check the fasting first and you adjust accordingly. And your prandial will take care of your postprandial glucose. So we need to be mindful of those things. And I've seen people being shocked at that. The patient is having 80. The patient is having 60 units of insulin. What do you do? Is it wrong? Is it a prescription error? It shouldn't be. What is the maximum for? Because I've seen a lot of people concerned about how much insulin the patient was on. And they would even say, this is too much. Let's assume that there is no adherence issue. Would you have a cap? Most of the insulin come as 100 units for 1 ml. But remember, you can have the 200. You can have the 300 in 1 ml. You can have 500 in 1 ml. Because they are patients that are very resistant to insulin, especially when they are obese. And how many of our patients are obese? That's why these U200 and 300 and 500 were created. Because otherwise it becomes too much to give. And once the patient needs more than 200 units, so they can need more than 200 units. In those settings where money is there and the resources are there and these drugs are available, they will move them to the U500 or the U200 or 300. So we need to know that. We give our insulin subcut most of the time as chronic management. And regular insulin in crisis is used as IV. Okay. And those are the areas where they inject that worth to be explained to the patient because they need to rotate to try to avoid some of the complications that arises, particularly if you repeat injection in the same spot or if you have a poor technique. But why do we need to cite absorption? What do you tell your patient? Especially when we only give them human insulin, isn't it? Is it different? And if it's different, how do you take advantage of those differences? Are there areas where it is absorbed faster? We need to know this. Okay. So the fastest area for absorption is the abdomen. So knowing that human insulin takes already time, so if you are giving atropine or atropine to take care of the prandial, you should advise your patient to use the abdomen. But if at night you need to prevent hypoglycemia, then you need to mind and give where it is the slowest, the legs or the buttocks. But meantime, you need also to know that if you give it in the legs and you start running, you absorb fast. So you cannot inject in the legs and go to the gym. So those are the things that we need to know and explain it to our patient and take advantage of those differences. So, yes.
Yeah, just to add that, in addition to IU or IN, so insulin also given by addition.
I didn't want to use the fancy one
so-
yet because we
Yeah.
don't have access to them. I've tried to keep it as practical as possible. So it is there. There are also pumps and so forth. I didn't want to address those issues. So
Been taken off the market, if there was some pulmonary issue that something country they tried a couple of years ago, it is off, we don't have.
no, it is back. It is back. It is back, yes. So now, when do you give them insulin? That was one of the reasons I was shocked last time when I asked you, did you start somebody on insulin? William say when they fail oral. That is the traditional indication. We need to be mindful. So if we all remember that we can give insulin from diagnosis in type 2 diabetes. So we should, all of us should have started somebody on insulin. And at any time, provided some criteria are met during the course of the disease, you should offer your patient insulin long before they fail oral. And that insulin that you start for this indication allows you to get your patient control faster, because it's not only about achieving control one day, but the earlier you achieve control, the better for your patient, because it is what they call the concept of glycemic legacy that you take care of. There is a price to pay when you let your patient living with hyperglycemia. And some of these new indications are HbA1c base greater than 10. So that HbA1c, when you take the baseline, it is also to tell you if the treatment that you've started your patient on is adequate or not. So when HbA1c comes, it is greater than 10, that is an indication for insulin. How many patients of us come with fasting blood glucose greater than 14? Plenty, every single day. Those patients from diagnosis or at any time, when they come to us and you see it has been consistently above 14, offer this patient insulin. Get them to target, then pull back insulin. Random blood glucose consistently greater than 16.5. Give them insulin. How many times did we run for blood glucose in casualty on a weekend, then Monday in what 5 for ketones that happen not to be DKA? Many times, isn't it? That is another indication for insulin. And when the patient comes and you take the history and you assess the patient, and the patient says, I've lost weight, that patient needs insulin. So you diagnose your patient, they lost weight, they should be on insulin. They've been diagnosed for years, they come, they've lost weight, they should be on insulin. So, and this, it was the other indication. So you've seen that beyond what we know, the one that failed oral, the one that is in hyperglycemic crisis, because after DKA, you go to insulin if you were on oral for a while, isn't it? Or if you are on oral and you happen to be admitted to deal with in hospital hyperglycemia, we give them insulin. Those are the traditional indication for insulin. But the paradigm shift, and what we should remember now is that every single patient with all other criteria that we've listed should be offered insulin. So, which regimen now do you give to your patient when you use those indications? They are newly diagnosed, or they were only on sulfonylurea, or they were only on metformin. Then they meet these criteria, they understand, and they want to control because they don't want to carry the burden of living with high sugar. Which insulin do you prescribe to them? It is intensive therapy. So intensive therapy in our setting will be atropine. I won't cover the basal bolus because that is another lecture, but basal bolus is also intensive therapy. So basically, whenever you want to start your patient for those indications, you need to offer them in our setting atropine. Same apply to patient that comes from the hospital after DKA. So if they come back to us, you should not go board the tablet. You should prescribe them atropine, or should understand why they were discharged with atropine. So now, what happened? It's coming. Okay, it's coming.
Okay. It's the, it doesn't affect the computer, it's just.
Yeah. So, and whenever we start them that atropine, in the background, there will be metformin that you will titrate to the usual dose that your patient needs. The usual dose, our patients are usually between 1,000 and 2,550. So this is your patient. You start your patient on, we usually say 0.3 unit per kg, but it is a range. So don't beat up on your colleague that chooses 0.4. Don't beat up on your colleague that chooses 0.2. It is a range. The mean of it is 0.3 unit per kg. And you will split it 2/3, 1/3. In the background, remember to give your patient metformin. But because it is intensive therapy, you see that the patient doesn't have sulfonylurea. So whenever you start intensive therapy, being it when the patient require, or being it as initiation or just as a temporary measure, you should never keep your patient on sulfonylurea. So now, if you prescribe, it means I've seen all of you sending Viva prescription around, isn't it? You are all comrade. Huh? You are all comrade. You take Viva check, isn't it? What do you monitor? What do you tell your patient to monitor? Because I've seen people drawing table, giving them to patient without telling the patient what is the target, when to check exactly, because they might bring you a table without time, or it is not in relation with what it should be with. How would you adjust your patient treatment? So what do you monitor for a patient on atropine? Because only God knows that 0.2 or 0.3 or 0.4 or 0.5 that you prescribe is enough for the patient, or even not too much for your patient. So you will need to adjust and you will need to monitor. What do you monitor? Those, you need to tell the patient those targets. And those targets depend on your HbA1c target. So the patient should leave not only to go poke himself or herself, record the blood glucose, but to know which blood glucose they are striving for. And it will be the morning and the evening, the preprandial. So the morning, basically, it is a fasting. So it will be the pre-morning injection and the pre-supper injection. So again, as we spoke about this already, you need to go back and tell your patient about this. And whenever you prescribe Viva strips, you have the duty, if your patient is not yet controlled, it's not just, it should be part of the prescription. It is there to assist you adjusting the treatment. So it doesn't make sense that you prescribe the Viva check, you prescribe the strips, but you never review the patient self-blood glucose monitoring. And some of these patients are so frustrated, they say, the other doctor told me to monitor, but when I came and saw the new doctor, he didn't even ask me. I had it in my bag, but they didn't even ask me about my monitoring. It is there for a purpose, because that's what will tell you to increase, to keep, or to decrease your patient insulin. And how do you titrate? Because we know what to start on. We know how much to start with. We know what will guide us to titrate our patient. But how do we titrate our patient?
Less than.
Hmm?
Less than 2 units there. 1 unit there.
How do you do it? So they bring you, it will depend on how motivated and how in touch you are with your patient. It can be +1, -1 on a daily basis. This can even be told to the patient. If you are off target, go 1 extra every single day until you reach the target, then you cruise. That is one of the easiest way to titrate. It can be done on a daily basis. Empower your patient. Let them feel in control. They will adhere. Then when they come back, the duty will only be to give you the paper, but also to tell you to change the dose on your prescription, because it might no longer be what they left with. It can be less or more. The one that we usually go for will be the weekly titration, but it will be 2 up or 2 down, using the average of the last 2 readings. I've seen people documenting, they take the whole paper and say the average blood glucose is 10 points. No, you don't need that. It doesn't make any difference for your patient to document that. Because even today, when you go insulin-wise, they are now talking about time in range. So if you want to emulate time in range, you should be documenting what was the percentage of the blood glucose that were on target. So if there was 10, 5 were on target, 5 were not on target. So, and whenever there is a hypo, what do you do? Because it can happen, because you should have spoken to your patient about that and tell your patient to report promptly if there is a hypoglycemia. It is one of the mistakes that we do. Some of the patients stay home for the whole month, getting hypos and hypos from time to time. Some of them stop taking treatment. By the time they come back, they are very, very hyperglycemic. When there is a hypo, it needs to be decreased, isn't it? By 10 to 20%. If the patient was getting 20% of 20 is 4 units, cut it down. They never say stop insulin. They say reduce insulin. Or you can just decide to cut down by 4 units. So those are things that we need to do for our patient safety. But remember, in South Africa, the 2/3, 1/3 might not work. And if you check, you will see that not all our patients currently, it's the ones that are adherent and that are controlled, have the split 2/3, 1/3. You might find your patient with a split 50-50. Why? Because our biggest meal is in the evening. If you just monitor your patient carefully going forward, when you start with 2/3, 1/3, you will see that as you optimize at the beginning, you'll keep on increasing the night insulin only, because they will always, or most of the time, have fasting that are off, while the supper, the afternoon or the evening blood glucose is normal. It is because our biggest meal in South Africa context is supper. So don't be shocked and wanna split, take the total dose and try to split it 2/3, 1. That is at the beginning, but once you go forward, you adjust your patient. You can adjust both, or you might only adjust one. And what will tell you what to adjust is the target that you've chosen for your patient. And we need to be mindful. There are even patients that have the reverse split. They have less in the morning and more at night. So if it does work for them, don't change. Just because you want to stick to the 2/3, 1/3. Okay? So for the patient that fails, what do you give them? We know what to give to the patient that starts de novo. We know what to give to the patient that is a complication. For the patient that require insulin, that don't meet those criteria, what do you give to your patient as insulin? You give them the basal. Okay? Most of our patients in type 2 will need basal when you want to start your insulin, if they did fail the oral. And in our setting, we say our basal is our intermediate insulin, which is Protafen. So how much do you start? So whenever we start them, they will always be, unless contraindicated, unless adjusted because of EGFR, they will be on the maximum of glimepiride and the maximum of metformin. You add Protafen and you keep the oral, unless contraindicated. But the other issue that I wanted to bring to you is that although on paper, glimepiride can be given up to 8 milligrams, it doesn't make any difference when you go beyond 4 milligrams. You see how much you only reduce by 0.1 in HbA1c. If your patient had a HbA1c of 11 and you want to push glimepiride to 8, would you ever get it to 7? Never. Remember that. And how do you adjust the basal? Remember what we say? We adjust the basal based on the fasting target. So when your patient is on protafen, all that you need to focus on is give me your fasting readings. And your fasting readings should be between 4 and 7. And as we say again, if you do it on a weekly basis, you average the last 2 and you decide if you need to go up by 2 or go down by 2. That's all.
So you're adding the protophane to the glimepiride?
You keep, yes, you keep glimepiride and metformin. So you can also do it on a daily basis. Patient really buy into the +1 -1. It's easy for the patient to do. And they get there faster, because if you need to wait a month for you to change by 1 unit or 2 units, what would they get there? So now the other issue is that 0.2, or you can just give them 10 units. The biggest issue now is what is your maximum for protafen? If you have a patient on protafen, when do you decide to move your patient from protafen to, because the next step is actafen, isn't it? That is our intensive therapy. There are some patients that are on protafen that might not be on target. What is the maximum? So remember that you cannot carry on increasing protafen forever. There is a ceiling effect with protafen. Whenever a patient reaches 0.5 units per kg of protafen, you've reached the ceiling. If they didn't get to the target, you need to move them to basal plus, or you need to move them to intensive therapy. So there is a maximum. Failure to do that, all that you get from your patient is putting up kgs and getting hypos. Then they will be frustrated that they don't get the target, but they only get a complication, and then they default the treatment. They lose trust in it. So let us remember 0.5 is unit per kg is the maximum for protafen. And at this stage, you move your patient to actafen. You can use the same amount that the patient was using as basal, but now you convert the insulin into protafen for the same dose, and you split 2/3, 1/3, or 50-50, depending on what your patient is eating. I hope we got the basics, and you can see that prescribing insulin is not that complicated. It is easy. It's only one drug. It's not like ARVs. You need first line, second line, third line. Third line that you don't even remember that somebody else prescribed for you. Isn't it? Here, you are in charge. You and your patient decide what works. So thank you very much.
I'm going to manage the online side of the questions. So if there's any questions from the floor, I'm going to repeat it in to make sure that everybody has heard it. Just mute people. There we go. So yeah, is there any questions from the floor?
In the setting of, because I think it's quite common that people with long-standing diabetes end up having quite severe chronic kidney disease. I think there was a lady I saw the other day who had been on metformin for years, and I saw in even 2017 she had a GFR of 13 or so. She'd been on metformin the whole time. 1 gram BE, I think. And so then in that setting, how do we, do we first go to protophane because then you're not using any orals, or is it, do you have to go straight to the intensive?
Yeah.
So we've just got a question here in terms of chronic kidney disease and the use of metformin. If you have somebody with chronic kidney disease when metformin is no longer indicated, how you introduce your insulin.
So remember, whatever will guide you will be first, is your patient meeting those other criteria? What is the patient fasting blood glucose or random blood glucose? What is the latest HbA1c of the patient? If the patient is losing weight or not, is the patient having ketone in urine or not? If yes to that question, to one of these questions, your patient need to be on intensive insulin therapy. So you will offer your patient Actrafane. But if not, you start because the patient would have been like a patient that failed oral, but not really in need of you getting to target faster because they are not far from the target. You give them protophane. But again, remember, even when I put the oral, I say provided that it is not contraindicated. Those doses of 1,000 to 2,550, it provided there is no contraindication and provided that there is no renal adjustment. Because if, for example, the eGFR is below 45, between 45 and 30, the maximum of metformin is 1 gram, 500 milligram twice a day. Again, the other issue in our setting that we need to remember is that if the patient is on metformin, your patient maximum is on dolutegravir, your patient maximum is also 1 gram. So if with 1 gram plus dolutegravir plus anything, the patient doesn't get to the target, you need to start insulin. You give the patient protophane.
Right, we've got a question here on the chat about Act Rapid. So as we usually give it in the Eastern Cape, as the peak is at 1.5 hours, would it be better to check the HGT at that time instead of after an hour? Because currently the HGT is repeated after an hour. I guess that's that lovely setting where we give Act Rapid in OPDs to make ourselves feel better with hypoglycemias. But generally in a scenario, if you've given Act Rapid, how quickly do you want to check that HGT again?
We should not be treating our patient with Act Rapid if it is not part of the basal plus or if it is not part of the basal bolus. Because we say again, we take care of diabetes. To take care of diabetes, you need to schedule your patient insulin. Find the reason why the patient is not controlled. Address the issue. If the patient is newly diagnosed, just initiate the patient on treatment and adjust accordingly. They will never come back to you for them. I think we should consider every time that we want to give Act Rapid as if we fail our patient. Yes. If you think that you are helping your patient by giving Act Rapid every time they come to you, you are failing your patient. You're failing your patient. It is as giving cotrimoxazole and not dealing with viral suppression. Exactly the same.
Any other questions from the group here?
So if a patient comes to you and they're on protophane, for example, and they're still not controlled and they're not getting to where they need to be, and you're at the point where you want to switch them to Actrafane, is there a way to convert the dosage, or do you just start a new Actrafane?
So the question just here is if you've got somebody on maximum dose of protophane, so that's at 0.5 units per kilogram, and you're now going to switch to Actrafane, do you start again from scratch or do you convert that dose?
You convert the amount of basal into the Actrafin. So if they were on 40 of Protafen, you start the patient with 40 of Actrafin that you split to 1/3. That is the principle. But remember also another issue is that you don't move to Actrafin only when they reach 0.5. The other indication of moving your patient from Protafen to Actrafin will be if they achieve the fasting, but the HbA1c is not on target. It means, obviously, you cannot continue Protafen because Protafen only, the basal insulin only help you dealing with fasting. If it did achieve fasting, even at a lower range, at less than 0.5, you don't need to push to 0.5 because it won't address the postprandial. Because if the fasting is on target, but they are not achieving the HbA1c, it means now they are off because the postprandial is off. And for you to deal with prandial, you need to give them the basal bolus, basal plus, or move them to Protafen. So those are some of the things that we need to remember. 0.5 is not a must, but something not to go beyond.
And then I've just got a question about using glimepiride and Actrafane.
No.
That's what I was, yeah. So we normally stop. But
We stop.
So we can use glimepiride when we introduce the Protafane.
Yes.
But once we switch to Actrafane, you stop the glimepiride.
So the
and then they'll just,
sulfonylurea must be stopped.
And then they'll just be on the metformin as well as their Actrafane.
Yes.
Thank you. Yes, just to clarify that.
Yes.
So it's not really, it's not just diabetes, not so much insulin, but is there a specific way that we convert someone who has been on glibenclamide from the clinic to glimepiride?
So there's just a quick important question here. We still see patients coming in on glibenclamide from the clinics, and we need to convert them all to glimepiride. We no longer like to use glibenclamide. Just a question here about the conversion. It is 1 to 2 milligram of glimepiride for 5 milligram of glibenclamide. So if they have 15 of glibenclamide, you give them 3 milligram of glimepiride. That is the conversion. So please look out for that. The glibenclamide has lots of problems and issues with that, especially in our kidney patients. No one should be on kidney or no kidney problem. No one should be put on glibenclamide or carry on glibenclamide. You need to switch the patient. The risk of hypos is very high. And when they get hypo, they lose adherence because it's fearful, it's terrifying for them. Great. And then there's another question there. Yes, thank you.
When you mentioned one of the indications of this line, we talked about the HbA1c being too high in diagnosis, let's say
Greater than 10.
Greater than 10.
Yes.
You mentioned that you can start the patient on the insulin regimen.
Yes.
And then you mentioned, and you
can stop.
Pulling that.
Yes.
You also, so you
just talk through that maybe.
Control the HbA1c.
So the question here is when you have a patient, you first diagnose them, say they've got an HbA1c of 14, and we need to start them on an insulin regimen to get them on track. But at which stage, what happens next? Ideally, when you get to 3 months, you get the HbA1c at 7, you pull back insulin and you carry on with. So once they're on target, you can actually take them off the insulin, and then they'll stay on the metformin and your sulfonylurea, and use your glimepiride. And you start monitoring the fasting, because once you remove, you start checking first the fasting. If the fasting is on target, you carry on. If the fasting is off, you go back to insulin. So if you've got those patients where early on you need to start the insulin or intensive therapy for all those reasons that Dr. Kay mentioned, then it doesn't mean the
No,
patient
the
necessarily
guideline mentioned.
sorry, then you don't put people necessarily on insulin for life. So you can just say to the patient, we need to get you onto target quickly. We're not going to manage this without insulin. And then once you get to them on target, then you manage them like any other patient that you have started on. Then you're going to put your metformin and you're going to increase, you know, your metformin dosages and your glimepiride dosages. But when you start the insulin, you'll also start the metformin.
Yes,
Yes.
absolutely.
So they will already also start the metformin, but you won't add the glimepiride until you've taken them off the insulin and they're not staying on target.
So the benefit here is not only to reach the target quicker, but is also to preserve the beta cell. Because the life in fast line, you exhaust your insulin fast. So by putting the patient on the insulin, not only you preserve complication and take care of this glycemic legacy, but you also get preserve the patient beta cell function. So they might stay on or rather longer than if you didn't do that.
And there's one last question here, which takes us really back to basics, but I think it's good to repeat that. And it's in terms of diagnosis. So how many times do you have an abnormal fasting blood glucose or random glucose to initiate them on insulin?
Isn't it that we, can somebody, I know the answer, but can somebody else give me the answer? How do you diagnose? Because there was also an issue where a patient came, was symptomatic. I think that we did with that patient together. And the patient was asked to come for a oral glucose tolerance test.
Okay.
So you know that to diagnose, we make a difference between is my patient symptomatic, is my patient not symptomatic. If my patient is unequivocally symptomatic, you diagnose your patient based on one test.
Whether it's fasting blood glucose or random blood glucose or HbA1c, if they're symptomatic, that's enough.
HbA1c, isn't it? When they're symptomatic, you just need a random, or you need a fasting. If it is there, it is enough. In a symptomatic patient, we don't use random. In a symptomatic patient, we use HbA1c, the fasting, or the glucose tolerance test. So people must be mindful of that. But in our setting, it is useless to order a HbA1c for you to diagnose your patient, because electronic gatekeeping will not allow you, because you need to repeat. When the patient is asymptomatic, you need to repeat. You need to test, and it should be the same test, because we've seen people diagnosing with one fasting and one HbA1c. No, it should be two fasting, or two HbA1c, or two glucose tolerance. So it should be the same test that you did, not two different tests.
So in our setting, in practice, actually, the only way for asymptomatic patients is to make sure you've got two definite fasting. And you need to counsel your patients on what you mean by fasting. That a cup of tea in the morning is not fasting. So it's just to make sure that it was clear, two definite readings of fasting sugars, and not the one that was done when they arrive in hospital.
But usually they also come to us, they were fasting, but it is only one reading. Then just ask them to go to the nearest clinic and do another one. Then come the following week. Then you have 2 or 3. Then you
use that for diagnosis, and you will similarly, in terms of making decisions about things like insulin, if they're asymptomatic. Okay, I think we're going to close this session.
Sorry, Dr. Muller.
Hold on. Yes.
I'm sorry. I was asking in terms of the criteria in terms of initiating insulin.
Okay.
Dr. KB mentioned if a patient has an abnormal fasting blood glucose, I think it was more than 17 or something, and also about a random blood glucose. So after how many times?
14.
After how many times do you have an abnormal reading of those?
Yes, it's usually said consistently, but you've seen patients at the clinic, it was there, they come to us, it is there. Give that patient two or three times. It is consistent. It must be the first time they did it, it was high. The second time they did it, it was high. Give your patient insulin. Is it fine? Is it clear?
No, I get you. I get you. Thank you.
Thank you very much for everybody joining in. Next